Good morning and welcome to our virtual event, Health Systems and Humanitarian Aid, the Race Against COVID-19, hosted by the Humanitarian Congress Vienna. My name is Andreas Papp. I'm the moderator of the panel discussion, and I want to start with a few housekeeping rules before I hand over to Annelies Willim, the director of the NGO umbrella organization Globale Verantwortung, or Global Responsibility in English. Annelies Willim is representing today 35 development and humanitarian NGOs in Austria. Together with the colleagues of 4 humanitarian NGOs, the team of Globale Verantwortung has organized this event. We would like to serve the audience with a lively discussion and encourage all of you to ask questions and give comments in the Q&A section, for the German's F&A section, at the lower end of your Zoom window. I will pick them up from time to time and forward them to our distinguished panelists in reading them, actually. We'll do our very best to answer as many questions as possible during this panel. Any unanswered questions we will try to answer in the follow-up of this event in the coming days or week. We are recording this webinar session and we will make it available on the Humanitarian Congress website also in a few days. With this, I hand over to Annelies Willim for her welcome note. Annelies, over to you.
Thank you, Andreas. I hope you can hear me. Everything fine? Good. Excellencies, representatives of governments, bilateral agencies, UN organizations and international bodies, members of the Austrian Parliament, representatives of civil society, distinguished guests, dear colleagues. On behalf of the team of the Humanitarian Congress Vienna, it is my great pleasure to welcome you to today's virtual conversation. And I would like to express a special and warm welcome to our panelists. Her Excellency Agnes Binagwaho, who joins us from Rwanda. Good morning, Professor. Christos Christou, joining us from London. Kalimera Ptimbieni. Her Excellency Desiree Schweizer, joining us from Vienna. Good morning, how are you? And Dr. Gerald Roggenscharp, joining us from Copenhagen. Good morning to you as well. It is really great to have you here. Thank you very much for sharing your expertise with us today. For more than 10 years, the Humanitarian Congress Vienna has been initiating discussions and brought together practitioners, policymakers, civil society, and experts from the private sector to discuss the role and impacts of humanitarian aid in interplay with politics, civil society, and other socially engaged actors, as well as to raise the visibility of humanitarian aid efforts. Although we miss the in-person interaction, today we continue this tradition with this virtual event. The war in Ukraine demonstrates to everybody a challenge that countries and societies of the global south are sadly very accustomed to, living in a world of multiple crises. A pandemic, epidemics, armed conflicts, impacts of the climate crisis, ecological, social and economic insecurities, and poverty. We all have to shoulder some burdens, but in many parts of the world, the pandemic is just another layer of misery, just one of people's many daily challenges. The inequalities and challenges we witness need both human and financial solidarity between and within societies and countries. And tragically, that has not always been forthcoming. In today's virtual conversation, we want to identify lessons learned from the pandemic so far, discuss the needs of affected populations in humanitarian crisis, find ways to strengthen the resilience of health systems, and particularly in countries of the global south, and the role of humanitarian aid during pandemics in the context of multiple crises. Of course, our shared world should be safe, not only for the few, but for all. And let us always remember, humanitarian aid is not an act of charity, it is a human right. I would like to wish you an inspiring time. Thank you very much, And back to you, Andreas.
Thank you, Annelies. Now let me introduce you to our panelists, and I want to remind you, for a more detailed biography, you can find them on our webpage, humanitariancongress.at. After a brief introduction, each panelist will be invited to give a statement of roughly 3 minutes with reference of our topic today. We start with Excellency Professor Agnes Binagwaho. She's a medical doctor by profession, specialized in pediatrics, and currently resides in Rwanda. She's the Vice Chancellor and co-founder of the University of Global Health Equity in 2015, an initiative of Partners in Health based in Rwanda, which focuses on a more equitable quality health service for all. Professor Binagwaho returned to Rwanda in 1996 and has served the Rwandan health sector since, building it up and in high-level government positions. Lastly, as Minister of Health for 5 years. She teaches at several universities around the globe and has published over 220 peer-reviewed articles and was named among the 100 most influential African women in 2020 and 2021. Professor Binagwaho, the floor is yours, please.
Thank you very much. Sorry, yes, I'm not on mute. Thank you very much for having me in these important conferences. Good morning to you all from Kigali, and it is a pleasure to be with you today discussing health system and humanitarian aid in the context of COVID-19 pandemic. This health crisis has highlighted various challenges that will take us hours to discuss and really have bring problem in front of all of us that we will not suppose that can happen at a period where we are in 2021, 2022, and even 2020. So this health crisis will make us discuss the real meaning of human and the real meaning of the humanitarian system that aid that we currently have around the world. I would like to focus on how the world approach to health delivery and health system support during the pandemic in developing countries has failed. We can take the example of the COVID vaccine that were distributed inequally with developing countries left last in the line. But also what has happened in some refugee camp in the developing country, notably near Greece, where people were living before COVID-19 in a very miserable condition and were left alone and not supported. Initiatives such as COVAX were put in place to ensure equitable delivery, but there was significant shortfall, such as funding shortage, supply bottleneck, delayed communication with developing countries. A major challenge is that this initiative now heavily relies on donation from high-income countries. Donation that rely on high-income countries benefits were not really well managed because they were afraid to not have enough for themselves, even when they have storage in the stock. Millions of doses of vaccine that expired in stock. 500% of doses they needed were in their stock. I can name many countries, even very far as Canada and other high developing countries that have stocked more than 200% of the doses they needed. So even though humanitarian assistance has helped us to respond to the crisis in the past, to some extent, we cannot fully rely on it, and we have to really rethink how it is done, why it is done, and how it can be more ethics. This is why there is a strong movement on the African continent now to increase research on local vaccine manufacturing. And this is not a bad thing, because if Africa contributes to produce what the world needs for its health, the humanitarian activities will focus more on other countries that are in need. Thank you very much.
Thank you very much, Professor Viinaguaho, for your statement. You have raised already some of the points we will later during the discussion will focus on. With this, I want to start with the introduction of our next guest and panelist, Dr. Gerald Rockenschaub, who is a medical doctor with a medical degree from the University of Graz in Austria. As World Health Organization Regional Emergency Director for Europe, he's supporting member states in their efforts to build sustainable prevention, preparedness, response, and recovery capacities, and to strengthen health systems resilience. He joined the World Health Organization in 2004 as a regional advisor and program manager. From 2014 till 2021, Dr. Rockenschaub was the head of the WHO office for the occupied Palestinian. I also know that he has just turned back from the Ukraine, so we will hear also how later how COVID-19 may have impacted the vulnerable groups there. Dr. Rockenschaub, for your statement, please, the floor is yours.
Thank you very much, Andreas. I hope you can hear me, and thanks very much for the nice introductory words. I would perhaps like to start along the lines of Professor Viinaguaho, that the COVID-19 pandemic has really exposed systemic weaknesses and capacity gaps of health systems across all countries, not only those affected by humanitarian crisis, but also those who are quite well resourced, but not only in countries, but also within the global and the regional health architecture. While the focus obviously needs to remain on efforts to reduce avoidable morbidity and mortality, we also need new innovative strategic approaches to be better prepared and build resilience to absorb future shocks and better manage future crises, both at the country level, but also at the global level. Learning the key lessons from the pandemic, we need those strategic interventions to build a fit-for-purpose global health architecture, to strengthen our comprehensive preparedness and response mechanisms, and to build more resilient health systems. I would perhaps just take a minute or two to reflect a bit on my experience during the pandemic in the Palestinian context that you mentioned, Andreas, because I think it puts a bit into the focus some of the broader concerns we were experiencing more generally: equity concerns, accountability concerns, ethic concerns. I mean, in the Gaza Strip, for instance, you're talking about the health system that has been on the brink of collapse through the chronic closure already before the pandemic hit, and it was very ill prepared to absorb any future shocks. The interesting fact, though, was that for quite some time, due to the closure and the very strict quarantine and isolation regimen that were introduced by the health authorities there, we didn't really see any meaningful explosion of case numbers. In fact, we had hardly any local spread for a number of months, 6 to 8 months. So of course, it was then not able to prevent it forever, but the strict quarantine at least worked in the early stages. But what happened then is once vaccines became available, I mean, equity really became a major issue, because it was, as a matter of fact, Israel went ahead at very early stages and vaccinated quite successfully, a substantial proportion of their population, while the Palestinians were left behind because they didn't have the resources to procure on global markets, and also they had some systemic challenges. So COVAX eventually became quite instrumental. I think Professor Pinaguaho mentioned it already, with all the shortcomings, but it was a vehicle to mobilize vaccine quantities and to start vaccination also in the Palestinian territory. But these equity concerns even, became very politicized in that context. And I think they take us to the broader complexities that we were facing and that we need to collectively address. I think everybody agrees that we need a global, more robust health architecture to address those equity concerns. There are negotiations now underway to potentially agree on a pandemic treaty or a convention that would put more accountability in the global system. I think we'll need to see where these negotiations go, but I'm pretty hopeful they would take us a step further based on the lessons learned from the pandemic, and would allow us to build a stronger global system that would allow also to mobilize resources to build robust local systems, because that's where the focus needs to lie. Thanks. Back to you, Andreas.
Thank you, Gerald. And we continue with Excellency Ambassador Desiree Schweitzer, who is a career diplomat and since 2018, the Director General for Development Cooperation and Humanitarian Assistance in the Federal Ministry of European and International Affairs. Prior to that, she was part of the senior management at the Secretariat of the OSCE with responsibility for environment and energy security issues. Ambassador Schweitzer has engaged in development and gender issues for over 30 years. She has been a member of the board and, until last month, president of UN Women Austria. Dr. Schweitzer, please, for your statement, the floor is yours.
Good morning, thank you, and thank you to the Humanitarian Congress team Vienna for keeping up the tradition and even bringing us together in a virtual format in years where it is not possible to meet in person. I'm trying not to repeat what has been said before, but it's clear that the COVID-19 pandemic is a drastic reminder of how closely interconnected the world is today. And the virus doesn't know any borders. The pandemic is not over until it's over everywhere, and we are not safe until everyone is safe. These words of the UN Secretary General I like to repeat over and over again because they are so true. So this requires more visibly than ever international cooperation, action, solidarity. And where do we stand today? I think that remarkable results worldwide have been achieved by the Access to COVID-19 Tools Accelerator, which is in its essence an exemplary alliance between governments, global health organizations, academia, civil society, and philanthropic organizations. And at the heart of this collaboration are the development of vaccines and ensuring the equitable access to vaccines for all, as well as support for capacity building in health systems. The current vaccination coverage was referred to, and I have a number here from the end of last month, which says that the current vaccination coverage stands at 58% of world population. But as was mentioned also by Dr. Pinaguaho, there is a large discrepancy between Africa with only 15% and the rest of the world. So getting vaccines to the global south, to rural areas, remains a major challenge. Austria has so far contributed close to 330 million euros to the fight against the pandemic and its consequences, and this includes bi- and multilateral vaccine donations and contributions to the COVAX AMC, this vaccine donating part of the ACT Accelerator. And in addition, we are providing vaccines from our own stocks, and of course participating in the EU's massive aid programs. You might have followed that right at the beginning of the pandemic, the concept of Team Europe was generated, and it comprises the combined efforts of the EU, its member states, and the financial institutions, so EIB, EBRD, and our national development banks, to support partner countries in coping with the consequences of the COVID-19 crisis. Beyond the global health crisis, there are, of course, consequences in practically all areas of life, economic development, stability, and peace. Development progress that has already been achieved is undone in many places. In countries that have already seen humanitarian crisis, the outbreak of COVID-19 has even exacerbated the acute humanitarian situation. The pandemic has had a particularly negative impact on women, children, and youth. Domestic violence and discrimination have increased and threaten to do so further. We've seen that hundreds of millions of children have less access to education than before the crisis. And despite the extensive international support, it is questionable whether the Sustainable Development Goals of the Agenda 2030 can be reached. We have already pessimistic forecasts that assume that poverty and hunger will not end by 2030. We know that globally extreme poverty is on the increase for the first time in 20 years. So the COVID crisis is certainly not the only crisis the world is confronted with today. Climate crisis and its consequences, hunger, droughts, natural disasters, and political crises will most certainly be there even once we manage to keep the virus under control. And you all know and follow the news what the major humanitarian crises these days that are reported on are, referring to Afghanistan, Syria, Yemen, and of course, Ukraine. Thank you.
Thank you, Ambassador. We continue our last, but certainly not least, when it comes to humanitarian assistance, Dr. Christos Christou, a surgeon by profession, who graduated at the Medical School of Greece. Since 2019, he has been appointed as the international president of Médecins Sans Frontières, or short MSF. His time with MSF started in 2003, when he worked with migrants and refugees in Greece. Since then, he participated in surgical missions in conflict zones and highly insecure contexts, such as South Sudan, Iraq, and Cameroon, just to name a few. Christou, a lot has been said. Your statement, please, to round up the first round, please.
Thank you, Andreas, and good morning, everybody. How can I have a statement after all these distinguished panelists that they have summarized almost everything that I would like to say? However, allow me to bring also another perspective here today, because there's a lot been said about how to better prepare for a future pandemic, but let us not forget that this pandemic is still not over. And there are places in the world that are still have been affected a lot, and they face serious challenges. For an organization like MSF, it is really worth it to bring to your attention some of what we call operational realities, the pragmatism in the field as we experience that these days. It is, let us just take a snapshot that I will try to summarize in 3 bullet points. My first one is that as it was already said, in many countries, the vaccination rate remains, I would say, stubbornly low. And now the supply seems not to be longer the major problem, but the absorption and uptake issues need to be addressed today in order to have this real progress that we need. In other words, we are shifting from vaccines to vaccination. And I can bring several reasons why. We can reiterate on that later, but different states, different countries, and different contexts have different barriers, different bottlenecks, like financing, demand and hesitancy, human resources, what we call health workforce, in-country supply chain, the data systems, and expired donated doses by COVAX. Just a few of the bottlenecks and barriers that we see in wherever we operate today. My second bullet point is related to the ripple effects that we have been seriously concerned since the beginning, and now we see the consequences of having systems that they have been focusing on one single disease and not on patients, not on communities the last more than 2 years. We see again the tuberculosis, HIV patients that have been lost to follow up. We see chronic diseases non-controlled. We have seen vaccination campaigns that have been seriously delayed, suspended, not ever done. And now we treat patients with measles again in places that we thought, and we hope that we have controlled these diseases. We see delayed screenings and specialist referrals for suspected cancers. And last but not least, of course, mental health issues, that this mental health crisis will persist well beyond this pandemic. And my last point, my third bullet point, is looking back, looking at this snapshot of today, what is next? And for our organization, and I think it has to be for everyone these days, we need again to take good care of all the health of our staff, the people that we have to protect first, all the vulnerable population, and I'm sure that we will talk about this later. We need to get prepared for the next COVID wave before we get prepared for any next pandemic. We have to keep monitoring any evolution, any progress in new vaccines, and keep pushing for waiving intellectual properties. But let us not forget that even this is not enough. We need a good sharing of know-how. We need to create these communities where we can exchange experience, know-how, technology, in order to have good COVID-related products, not only vaccines. And of course, we have to promote this integration of COVID-related activities to all other type of activities that we may have as organizations when we intervene in the humanitarian world. So this is roughly some ideas that we are working on these days, and I'm happy to elaborate later. Thank you, Andreas.
Thank you very much, Dr. Christou. I have a question from the audience, which touches one point which has mentioned already, the vulnerable groups. More concretely, a question of Johanna Mang, a fellow colleague from Lights for the World NGO. And the question is addressed to Dr. Binagwaho about her experience in Africa in the inclusion of persons with disabilities in the health response to COVID. I then extend the question about the most vulnerable groups to the other colleagues. Who are they, and how can we make sure that we're able to reach them? But first, Professor Binagwaho, people with disabilities. Can you share with us your experience on that, please?
Sorry, I broke a bit. The question is directed to me?
Yes, the question is, yes, please.
So what we did with people with disabilities.
Yes, correct.
During the pandemic. So I have to say that it's, there are other questions that are related with that. We need a resilient system. We are not going to build during COVID a system to take care of disability. So what exists for people with disabilities, there is, in each district, there is somebody in the office of the mayor that is in charge to make sure that they are not excluded for other things, like to access to HIV treatment, for example, to access to anything. So they have a strong national umbrella representing the NGO of people living with disabilities, and they are on the table when the measure are decided, the measure, what we do with lockdown, because they were not the only people that are vulnerable. The very poor who need to work today to eat tomorrow are also very vulnerable when you say nobody moved from the house. So systems were in place and the vulnerabilities were pulled together. We have a system of 200 houses in Rwanda with a head of village elected by the village. For me, we have one. I know where it is. And the head of the village was in charge during COVID to mitigate the impact of the measure, preventive measure or response measure for all people. So those who cannot work, the community health workers, we have 4 in each village, go at home and say, and without entering, they were allowed to circulate in the village, say, do you have any problem on daily basis, etc. If someone has a problem, call an ambulance, bring them in a center doing the testing. And for the people who are handicapped and living with handicap and poor, the response was fully free, like for all Rwandan during more than a year. But now, for example, if they have to test and there is a phone call they can call, I have to test, I have no money. They come, they are taken, they go to test. Just because, even if we have in one village a family living with a person who may be positive but cannot test, cannot follow the measure, all the village is at risk. So it's an overall system where all citizen is taken care of according to the means we have. Yeah, there are many things we cannot do, but what we can do, we share it. And it's not built during the pandemic. It's something that has built over time, improved, and it's a continuous journey.
Thank you, Professor. I will lead over now to Gerald, as you have just turned back from the Ukraine, where the war is roaring up in many places. Talking about the most vulnerable, looking at the refugees, looking at the population who is trapped in between front lines. Is COVID a topic for them? And more generally, from your perspective, who are the most vulnerable groups? And again, how can we make sure to reach them?
Well, COVID is a topic, Andreas, but it's certainly not the priority topic. I think people literally struggle to survive at the moment, particularly in those areas that, you know, are experiencing quite desperate humanitarian situations like Mariupol and so forth. I think in terms of, well, in Ukraine, we had historically always a challenge with vaccination rates that were historically low for a number of reasons. I mean, we had measles outbreaks in the past. We also had polio cases, vaccine-derived polio cases relatively recently. And also with Corona, I mean, vaccination uptake remained a challenge. I mean, we have average vaccination rate of 37% of the population, but with quite substantial geographic variations in the coverage. But in terms of vulnerable groups more broadly, I think what Corona also brought to the forefront is well, first of all, it's elderly people who were really vulnerable and in very well-developed countries as well, and those with pre-existing conditions. But then I think there was a whole new group of vulnerable people that developed, which were those with chronic conditions who could no longer access services because of reprioritization of services, because of access problems, even to hospitals, because of postponement of essential treatment regimen, because of limited capacities in health systems and in health facilities. And I think we have now another group of vulnerable people who are experiencing post-COVID condition or long COVID that I think we also need to start focusing, because there are these, well, we don't really know exactly, but 10 to 20% of people who are experiencing longer term consequences of a COVID infection that will require dedicated chronic support and interventions in that respect. So I think a whole lot of package of new challenges that we have in front of us that we need to collectively tackle.
Thank you. Again, turning our focus away from Africa or Central Europe, more towards Asia or more concretely the country of Afghanistan.
Dear Andreas, can I say something when I'm responding?
Sure. Please just raise your hand. That's the easiest way to show me that you want to say something. Just raise your hand, then I'll be silent. Wonderful.
I want to say that my response is according to my personal experience. In Africa, we have 54 countries. I'm not talking about other countries. I want to be clear because that's what I wanted to say. I want to talk about my personal experience, things I stand for and I can die for. Thank you.
Thanks, Professor Binaguajo, to clarify that. Again, then I would like to continue with Ambassador Schweitzer about the women in Afghanistan, particularly after the armed opposition, or better known as Taliban, have taken over the country. What's their situation? Can you share a bit what we, us, you, as a representative of the state and UN Women can do for these vulnerable groups?
Thank you very much. Well, as it was mentioned, the COVID-19 crisis has disproportionately affected groups that already faced a dire situation. And we see that the scale of suffering in Afghanistan is horrific, and the number of people, especially from the most vulnerable segments, in need of humanitarian assistance is increasing. We have seen numbers that about 23 million people in Afghanistan, and that's over half of the population is in need of humanitarian aid, and over half of that are children. And the number of IDPs is increasing. Afghan refugees are going to neighboring countries. Also, this we've seen in Ukraine. This number has also reached terrible proportions. In Afghanistan, 2.6 million people have fled the country in recent months. And I want to focus a bit on the women because you asked me about that, what we're doing for the women in Afghanistan. After the takeover of the Taliban last August, Austria has immediately decided to provide assistance via various international organizations. A package of 20 million was provided, and it dispersed over via UNHCR, the World Food Programme, ICRC, and 5 million of that went to UN Women. And the important thing to assist effectively, I think, is trusted partnerships, and that's why we decided to work with UN Women, because we have a long-standing cooperation with this organization, and the organization is well placed in the country. And as you know, the UN is responding to crises in the countries it operates in as a Team Europe. So it's not only UN Women who has to assess situations and work with their network, but they have the whole network of the UN and the coordination mechanisms with the UN. Why do we want to support and work with UN Women in Afghanistan? Because they have a certain focus on strengthening the role of women, also in the coordination of humanitarian assistance. And we want to ensure that humanitarian action is gender responsive. That is something that is very new in the discussion and getting even stronger. For that, we need the necessary gender analysis. In the assessment of humanitarian needs, we need the planning documents that reflect that. And in addition, we see a pivotal role for local knowledge in shaping the humanitarian response. And in this context, we highly appreciate the work of the Afghan Women Advisory Group that is advising the humanitarian country team. And they know exactly what women need in Afghanistan in their daily, from day to day. And we want to stress over and over again that women and humanitarian action is not a question of rights, but a practical necessity. And we need to strengthen women's livelihoods. That's another aspect of how the crisis has affected the situation of women. The income generation activities have been disrupted or lost, and there's shrinking space for women's employment. and with particularly dire consequences for women in rural areas or women-headed households. To address this challenge, we, through UN Women, support cash-based initiatives to provide immediate resources as well as skills training and seed capital to strengthen women's economic agency and enhance resilience. So women and girls must be at front and center in our efforts to tackle the crisis in Afghanistan, and also in responding to the impacts of climate change, natural disasters, and the other conflicts and humanitarian crises we see emerging at the same time. Thank you.
Thank you, Ambassador Schweitzer, focusing on the women in Afghanistan. Dr. Christou, when looking at MSF and treating or reaching more than 10 million patients a year, how do you make decisions when a pandemic hits us, especially in the beginning when you don't know the impact on the most vulnerable? How can you share a bit this situation where you have to direct the money, the resources, the human resources, your colleagues? How is the decision making in an organization as MSF going on?
Oh, very good question, Andreas, because indeed the very first months of the pandemic, we found ourselves with confronted with these dilemmas of where to go, where not to go, where are the needs. And we had to be really open-minded in understanding and identifying the vulnerability related to this pandemic in a different way that we used to do operations in the past. And that's why we found ourselves to places that we could never imagine that we would be intervening. In the center of Brussels, in New York, in Europe. And the reason is exactly the question that you addressed also to my distinguished co-panelists about who are these vulnerable groups. And in different contexts, in different states, there were different vulnerable groups. We confronted with this shameful situation in Europe at the beginning of the pandemic where residents of nursing homes were abandoned. And next to them are residents of prisons or homeless people, IVD, drug users. We found indigenous population in the Amazonas that were abandoned in a situation where we all are aware of how the Brazilian state faced and treated this pandemic, especially in the early stages. And of course, we knew that the people in the refugee camps in Bangladesh, the Rohingya population in Cox's Bazar, the ones that they are in the detention centers in the Greek islands or in the Mexican borders, and of course all the people affected by conflicts, like the one that we see in Syria, in Yemen, in Afghanistan, as Dr. Schweitzer mentioned before. This would be, of course, one of the first that they will be seriously affected. So vulnerability was different. The situation was really challenging. And our answer was to, in a very open-minded way, to mobilize all local resources, all the people that they carry this experience of treating other pandemics or epidemics in the past, and share this knowledge with well-advanced health system, but they were never aware of how to react in an epidemic. And that helped us a lot. It drew a lot of lessons for us that we now need to learn from. Thank you.
Thanks. That brings me to another question, because it has mentioned many times now. How can we make health systems more resilient? I mean, certainly we need to work closer together, states, NGOs, the local community-based organizations, etc., etc. From the 2 years of experience you have, what are the main conclusions of how to make health systems more resilient? And I would like to start with Gerald Rockenschaub from his point of view, what is needed, please.
Thanks, Andreas. I think a very important question. I think in many of our countries, health for too long was regarded rather as an expenditure than an investment. And I think this really needs to change. I mean, health systems obviously need to be adequately resourced to face a similar challenge in the future. I think we need to build the health workforce. We also need to make health professionals or occupations in health more attractive. I mean, we have these massive challenges around the nursing workforce where, you know, people are getting burned out, are leaving the profession, partially because it's not attractive financially, but also the workload is immense. People are overloaded. So I think we need to make those professions more attractive. We can no longer rely with, which unfortunately many countries, particularly in Western Europe, are doing on health workforce migration, because if you look at the reality on the ground, a quite substantial part of the health workforce is actually health workforce migrants who were coming from other countries who fill basically existing gaps, which is also from an equity perspective something that needs to be addressed. And I think we really need to address this at the highest political level. I think efforts are on the way. I think health has been put to the forefront. It is becoming an increasing priority that is no longer an exclusive agenda of ministries of health. I think it is increasingly regarded also as a priority for heads of states, for prime ministers, for chancellors. And I think we need to harness this momentum to advocate collectively for more investments in health, for strengthening health systems capacities and building more robust and resilient health systems that are in a position to absorb future shocks better than they did with the pandemic.
Thanks, Gerald. Professor Viinaguahu, what is your take on that? More resilient health systems. What do we need to do? You're muted. You're muted, sorry.
I tried not to disturb in between questions.
Mm-hmm.
I think the resilient health system is built in between crises. You take lesson during crisis, and after that you apply that on the day-to-day basis. And when we had in this part of the world the Ebola crisis, that it was a matter of all the continent, even if only 3 countries were really affected, and 2 countries had other countries had cases. At that time, we talk about, it was 2014 the first time, we talk about building resilience. We didn't maybe not say the word resilient, but we need to talk about strengthening health system to take such a shock. And we worked on that, because if you don't have an inclusive health system in between crises, you will not have an inclusive response to that crisis. So when I talk about how we have structured the care of handicapped people, of course, we are limited by money. All the people who need a wheelchair doesn't have a good wheelchair, but we know where they are. And when there is a wheelchair, we bring the wheelchair to the next one who need it, and we mobilize for wheelchair. So to have a resilient health system, we need to have the health system that is not managed only by the Ministry of Health. We have to need good connection with the Minister of Transport, electricity. We need to also keep ourselves informed about science. COVID was new, we didn't know. Remember when we were shocked knowing that we need fridge with mean 70 Celsius degree to receive the vaccine for Pfizer. So we need to create the logistics. We are not going to create a good logistic for vaccine distribution if we don't have a good logistics to distribute diphtheria, tetanus, polio, TB vaccine. So we did that. So we need to have a plan. You are not going to identify all the people with underlying condition the day we need it. So we ask all district, hospital, and health center to send the list of the people they care regularly, but we need a system for that. And we need an organization, sorry, we need an organization to collect those data and to make it a national plan. And our plan was led by the Prime Minister. The list, don't try that I was vaccinated before somebody who needed first, because the Prime Minister was watching. So we need accountability. You see, we need equity on day-to-day basis. Even if you are not rich, share what you have. Create a system that even the prison, I was so shocked to see how many people die in the US. In Rwanda, in our prison, when it was a matter to vaccinate all the people above 60, they were vaccinated too. Refugee camp, they were vaccinated too. So those things are, you create inclusion before the problem so that you just implement. Resiliency is a work of peace. Resiliency is a work when you don't have a threat, so you just implement. And when you have a threat, you take lesson of what didn't work well to apply immediately when you can.
Thank you for that. Thank you. I see Dr. Christos smiling. Would you like to comment on that?
Thank you, Agnes. Really, that's exactly the point here. This is our experience as well. And you mentioned and you phrased that so well about resilience, about inclusivity, about systems that they can do more. And of course, we should not underestimate the importance of money and finances. But still, the lessons that especially this part of the world has learned from different previous very serious epidemics like the Ebola is the ones that can lead all the world in a paradigm shift, in something that we need to be better prepared for the future. And I'm not saying that the problems were the same in all different places. My experience from my little country, but still perceived to be one of the high-income countries, was that there was a systematic underfunding of the public health system the last many years that maintained this approach as neoliberals in the very recent years of the pandemic. And that ended up having one of the worst death rates related to the pandemic because there was this underfunding of the system. In other sides of the world, the problems were different. And some of them were related to the fact that there was a kind of obsession on the COVID, neglecting all other problems. So there, and I think everywhere, if we adopt a more patient-centered approach, if we engage with the communities and try to listen and understand that there are real challenges, then we will see what is the role of COVID within a society and how you can make them partners in health and addressing these issues. These are some things, of course, without, I repeat, neglecting the importance also of the importance of serious funding and serious investment in structures and human resources in what we call public health systems all over the world. Thank you.
Thank you very much. I have a question here coming from the audience, which is somehow related also to this systemic change which is needed. And when I have taken here some notes, Professor Binagwaho said, we have to make plans for the next one between the crises. And Peter Hulsrøe, who supported the promotion of humanitarian telemedicine among the space community in the past years tremendously, has asked the question, is a global fund for pandemic preparedness one way of creating a more solid structure of this sort of disaster? Because we also heard limited resources, we have no money. Is this something we should work on? Anyone to answer?
So can I say something?
Sure, please.
I just want to say that well, of course, we always like money. And it's not me coming from a country where we have $800 per capita that I'm going to argue with this, where you all come from a country where you have 300 to 100 times more than we have. It's about system. With $1, the dollar you put in the system, put it to making resilient as you can. So money is an issue. I agree with you. But Rwanda and response of COVID in Rwanda have to show the world that we have to, of course, I will cry after money from morning to night. Don't worry, because we need to do more. But the money we have, use it well. You understand? So it's more a systemic, a vision. It's even an academic, an intellectual and political issue. A systemic issue. So it's a systemic approach. Inclusion, when you have $100, using it with inclusivity, it's possible. When you have $100, use it in your system to make it resilient, it is possible. So that all countries stop to cry and use the money they have for that, the world will be better. Because look, the countries who have done so badly. Those are countries who have $1,000 per capita. So it's not a matter of money. It's a matter of respect of human. It's a matter of creating a system human-centered. It's a matter of serving the vulnerable first. Then it will work.
And maybe just to add here that, yes, it's much about the system, but it's also about this spirit of solidarity that all our leaders so openly and every time repeated, but they didn't mean it at the end of the day. They didn't treat COVID-related products as common goods, as they promised to us. They, of course, invested a lot in science, and with public funds, science delivered. But then what science delivered was not distributed equally to the world. So in the end, again, they left the free market to apply the rules and resolve the problem. But we know that especially in a pandemic, it's not an opportunity to make profits as it happened again today. It should be a real opportunity to show solidarity. And I think in the future, to answer also this question about the Global Fund, we may have better mechanisms. We may learn a lot from maybe weaknesses that COVAX or other alliances may have had so far. And I'm sure that we can improve the systems, but as long as we will have the same approach, and especially the leaders of the world, nothing will really change fundamentally.
Christos, don't forget, the rich became 600 times more richer in 2 years. Can you imagine a world where we are living, where the majority of the people became poor, with more vulnerability, and the rich have 600 times bigger fortune? And I don't believe, Christophe, that it's by chance. We have a global system designed for that.
Well, again, true words, but I fear that humanitarians won't change that about the 600 times. But anyway, I want to hand over to Gerald, who raised his hand. Please, Gerald.
Yeah, thanks. I just wanted to come back to the question of a global fund or whatever. If you look at the recommendations of the independent panel on pandemic preparedness and response, which I think is sort of the strategic directions globally now, their recommendations, they clearly talk about a new financing mechanism that should be considered. I think what we also need is a pre-negotiated platform for access to medical countermeasures in the future, because I think what we saw is nationalism and egocentrics dominating over solidarity, and I think we need to have a global mechanism to handle these dilemmas better in the future. And I think some of the recommendations certainly go into that direction, like to establish a global pandemic treaty, a global health threats council at the heads of state level that could eventually address those challenges more effectively in the future.
Thank you. It was a WHA report I was just reading. It was issued, I think, 2 or 3 days ago, where I found the map of showing the significant disparities between regions when it comes to the distribution of vaccines. And least developed countries in Africa, Asia, South America have received below than 20% of the vaccines. And it has been mentioned some of the countries of the North have 400, 500, 600% of vaccines compared to the number of people they could vaccine. How can we change that? How can this be changed? I mean, we hear a lot about government saying we distribute more vaccines there. There is COVAX, there are many international, but as a result, after 2 years, one view on this map of your report shows it all. How can this be changed? Christo, please.
Not that I have the solution then, but I can look at what happened, and I can carry on with my thoughts, and what also was very well stated by Professor Binabajo about the inequalities in the world. And the models that have been used the last 2 years are those of what we call a charity approach. So we have something, we donate, this is the surplus that we may have, take it or whatever. We have to shift from such models. We have to treat all different parts of the world equally as equal partners. And we know that, we have seen that it can work. We have recent examples from Africa, which of course is not one thing. It's a huge place, but we know what Rwanda can do. We know what South Africa can do. We know that hubs of knowledge can flourish there. They can really produce things that can help the rest of the world. So to me, this is the fundamental thing, that we shift from a charity model, a charity approach where we donate, we support, we may show pityness or whatever to other side of the world, to something that treats the whole world equally as equal partners. If we can have at least this as a first step, then we can see things that we may have not even imagined.
Any response to that directly from the other panelists, or in addition?
Yeah, I think there is this concept of global public goods that I think everybody needs to have the right, very well defined, to have equal access to those global public goods. And I think some of those global public goods are certainly medical countermeasures, vaccines, and so forth. So I fully agree with Christo that, you know, this needs to be taken forward at the highest political level, and we need more solidarity and not this approach of giving away what countries have in surplus, because that created a whole lot of other challenges. Even COVAX had quite substantial difficulties and challenges, because often those vaccines that were donated had a very short shelf life, so the systems couldn't really absorb it in time, and it often were also vaccines that the recipient countries didn't necessarily want, and so a whole lot of challenge really in that respect. And I fully agree that I think the international community needs to do more, not only discuss solidarity, but live solidarity in the future.
Gerard, I'm going to be a little bit more precise. Those vaccine was sent by purpose, kept in high-income country up to the last minute. So, and sent to us because the high-income country knew that they will expire on shelf. And they knew that with a vaccine, a branch of vaccine that will expire in 3 weeks, that come without notice, that's also something. How do you want country? So again, they took the low-income country as their dustbin. It's not solidarity. Solidarity is to give us vaccine that have 6 months, 1 year, like you use for your own people. That is solidarity. The rest is taking us as a dustbin. And a lack of global accountability. We need more than solidarity. We need a legal framework for accountability. When you do a commitment, you have to feel it. Then you do a commitment to please your people, to show the developing world that you are the best person. In fact, you are not, and you know what you prepare. So we need also a legal framework for accountability. Sending us vaccine, there are some who are going to expire in 1 week. So it's a scandal. It's not even by chance. It's not even genuine. It's taking the developing world as a dustbin. So we are absolutely at the opposite of solidarity.
Thank you. Thank you, Agnes. Ambassador Schweitzer, can you share a bit of light on the discussion at the European level? How this mechanism of solidarity is lived there? These consultation between states of how to respond, how to share vaccines. If you have been involved in these discussions, or if you can tell us a bit more about on a state level, how does this work?
Thank you. I wanted to add, there are a lot of points to add to the previous discussion, and I think that the importance of functioning healthcare systems, that was brought to the attention of everybody, as also wealthy nations saw that their systems were brought to the brink of a collapse. And I think that the poorer countries are in even more, of course, difficult situation here. We also know that, as was mentioned, not only the most expensive measures are the ones that work. In our bilateral work in development cooperation, WASH is a very important area, water and sanitation and hygiene. And we, of course, what we're discussing now is not really humanitarian assistance, but basically already the nexus to the development cooperation. And strengthening healthcare systems typically takes place in the framework of our longer term planned development cooperation program. We had some examples last year where we embarked on that in the so-called consortium programs with Austrian NGOs. And of course, what was said before, I can only underline that we need to coordinate even more. Donors need to coordinate even more. We need to be in contact and get the report from local communities, what is needed. We are working closely with international organizations because they have their network of local partners in the countries. So the products are delivered that are needed, and we have to strengthen the capacities. The European Union, I mentioned the Team Europe approach, is focusing on the most affected countries in need of health supports. That are countries in Africa, in the neighborhood, the Western Balkans, the Middle East, and North Africa, in parts of Asia and the Pacific, Latin America and the Caribbean. But the EU cannot do it alone. But I mean, I think the EU, as the largest development donor for development cooperation and partner for development cooperation, is here at the forefront. And believe me, the discussions are ongoing on how to even make our response more efficient and more effective, and focus on the needs of the most vulnerable countries, most vulnerable groups. And I know that Team Europe is also working on an initiative, and that was discussed in many areas already, for manufacturing and access to vaccines manufacturing in Africa. supporting the setup of regional manufacturing hubs. That could be a model that could be associated with other regions in the future. So I think a lot of this coordination on how can we do it better is going on, and we are looking for tailor-made approaches. Thank you.
Thank you. Professor
Andreas, can I?
Sure.
Can I add something?
Sure.
Is that we know what works. The world seems to wake up, but for me here, I know it since 2003 when I was running the National AIDS Control Commission. You need a solid primary care if you want to do something good in any place. You need it to be geographically equitable, access to women and people with vulnerability. That's the step. Now, tell me, when you come and pretend to helping me, why are you pushing me to do something else? Because the way the high-income country are helping, the low-income country is with conditionalities. You do this for this, etc., and they need people who have strong argument, who are ready to fight, like we have here, to do it differently. So this, we have to get out of this hypocrisy ourselves. If you want countries to be ready next time, help them first to build a system that is integrated, coordinated. Not only send me pills to give, send me a system that the pill I give will be secure for the one who give it and for the one who receive it. All the procurement chain, etc. Those are things that donors doesn't want to support. And after that, we are surprised that we doesn't have a system. It's like having a roof, but doesn't have wall to sustain it. You see, so we know what works. We should stop to be blind ourselves and accept support in area that will not making work the next time.
Thank you, but I think that all we do in our development strategies, when they are developed, and we are sitting down with the partners in the country and we are working together. So the development strategies of our partner country is our guiding principle when developing our strategies. And I know that the same is true for the European Union. There are rounds of negotiations in the country with all the partners that are active there, with the bilateral actors, with the international actors. And I'm surprised that you say that the pills are being sent and no coordination is happening.
A coordination have to be functional, Dr. Desiree. And I know that the European Union supports things. I know you supported the country when I was there for nutrition, but I had to fight with you the way I want to build it. That's what I want to say. Could we sit together and learn from each other? Because I don't say that, let's say something, there is more knowledge in high-income countries, so you have less excuse to support something that will not work in 20 years. That's what I want to say. We know what works. Can we focus on that in the support we give and in the system we build? That's what I want to say, Dr. Desiree.
Okay, thank you. I think we will share this also with our colleagues in the Ministry of Health, and we know we have a broad approach when developing our strategies. We can always improve more, I think.
And we are happy to facilitate such a discussion, but this is another story. Please, Gerald, you have raised your hand.
Yeah, I just wanted to come in because I think it relates a bit to the issue that Agnes raised. I think we do have a challenge in coordinating humanitarian interventions and development interventions. We are trying at the UN level to foster this this humanitarian development peace nexus approach, but often the challenge is really in the details. I mean, if you look at practice at the country level, it's always that the humanitarian donors have vertical funding streams and development donors have separate funding streams, and to bring those two together is often very, very difficult and complicated, despite goodwills even at the donor side. But even internally, they have often problems. And I had a lot of donor discussions in the Palestinian context, where often the humanitarian side of the house said, well, you know, we really have difficulties to engage our development arm of the same embassy because, you know, one piece is linked to political discussions and has more a political agenda in putting it forward, whereas, you know, humanitarians are usually a bit more flexible in mobilizing resources, but to bring those pieces together and to tailor it towards the country context and the country needs, and to do everything with the systems building perspective, as Agnes was highlighting, I think that's the real challenge. And I think we are making some progress, but we are far from being anywhere close where we should be in that context.
So, Gerald, what needs to be done? So we are far from it. So can you give us 3 points what you would change, what you think needs to change to come that closer, what you have just said?
I think donors need to bring their two arms closer together, and I think everything needs to be done in a coordinated approach, government-led by the recipient countries. Of course, in conflict contexts, that might become a bit complicated, particularly where governments are part of the problem. Then that's easier said than done. But you know, I think there is. We had a number of attempts in the Palestinian context, you know, trying to stretch out the humanitarian response plan from 1 year's planning cycle to 3 years planning cycle, trying to bring the development partners on board. I think it depends very much on the country context. Perhaps there is no, you know, one size fits all, but a closer coordination between humanitarian actors and development actors is certainly the strategic direction that needs to be strengthened.
Okay, thank you. Christos, a question directed to you. How should I say that now? MSF is not famous, or not always famous, for coordinating to the highest possible level as it could be. Very often, because MSF and the ICRC are the only ones in the field with a handful of local organizations. But what could we do, the community of NGOs? We have the development actors and we have the humanitarian actors to work more closely together. Is there anything what you could share? Because coordination was mentioned so many times.
Thank you, Andreas. And in fact, this is true. It was something that when I took over in this movement, was one of the realities that maybe for some people made them feel very proud. We are still very efficient. We are in the forefront. We are there where you don't see many others. But at the same time, we all try to understand why the outcome of this help is not really multiplied as we would like to see it. And especially learning from very recent epidemics or other crises where we again intervened with the same old-fashioned model of coming with our resources from outside, being there within the first 48 hours, doing our best very efficiently, and we don't see what we would like to see as an outcome, made us really consider what we call also our operational models. And there were two incidents, actually, I don't know if I can call them incidents, two things that really shocked this movement of MSF. The one was, of course, the COVID, and the other one was all the societal outrage of the Black Lives Matter. We understood that very many systematic and institutional discriminations were going on within the movement, that they were not only related to how you treat your own people, how you help them to develop or not, but it was mainly related to what we call institutional and operational model approach. And there we realized that there's a lot that needs to be done. Very, very much in what Professor Binaga mentioned before. We used to have these paternalistic approaches. I'm the doctor, you're the patient, I know how to help you. You stay there, don't talk, and let me help you. And this doesn't work. When as doctors all over the world, we shifted to a patient-centered approach, we saw immediately the multiplication of the outcomes. We saw that together we can co-design a strategy to help the patient treat himself. The same applies to societies. In the same exactly way, you need to engage with the societies, listen from them. And the example of the Ebola for MSF, it is a very simple and typical one. While we were, with the rest of the medical society, focusing on how to treat the Ebola and get rid of an Ebola, there were mothers there that they had several other problems, malnutrition, malaria, measles, and they were trying to address this problem to us. And we were neglecting all these other situations because we were focused on that. So that's why it's important to really listen, to make this shift. Again, is about shifting mentalities and adopting different approaches. Many people say that this is a decolonized model. I am not very familiar with these terms. But whatever it is, at the end of the day, it is a model where you treat equally the different partners, either doctor towards the patient or the one who wants to support the other. And there we can see much of the difference. And I'm not sure if I'm really answering your question. I try to be very conceptual today, but yeah, I get inspired by also my panelists that they really address very brilliantly all the other topics.
Thank you, Chris. You did well. Thank you for your openness about also MSF and the challenges within the organization to change all that. I have a question here coming from the audience, basically also touching this issue of giving the population, the civil society, a word. How can we make sure that people are heard, that we do things as you have also explained? I'm the doctor, you're the patient. How is this possible? Or do you have any advice or example how this might work when it comes to the response to a pandemic?
Maybe I can continue because I felt like I haven't answered all your questions about partnerships also, which are very important. Yes, we talked about communities, and I see Gerald shaking the hand because indeed WHO is also very much towards this, how to make the best use of civil society organizations everywhere they are. And I think also for MSF, there is a long way to go there. Where we definitely need to be working together, especially with those that they are there even before we come. They are there the very first moment. They are the people mobilized from the surrounding communities to provide aid in whatever the problem is. Is it a disaster, a pandemic, or a conflict? And in the same sense, when you want to become the voice of your people, of your patients, of those that you support, you just need to listen first to them and actively listen to them, what they want to tell you, and then tell it is as it is. Try to find simple words. And I know that this is extremely challenging, especially for organizations that they have to be also neutral, impartial, and be guided by the principle of humanity. And very recently, we are faced with such challenges also in the Ukrainian context, where while most of the world is taking the side of, let's say, Ukraine in this war, MSF and all the organizations, the humanitarian organizations need to be present, access those that they are most in need, and do it with this spirit of neutrality, but without neglecting the importance also at the same time to bear witness and tell it as it is. There, of course, on the paper it's easy, but in reality, it is only the engagement with others, and especially the civil society, that can help you in such tricky moments.
Thank you very much. Any response to that? Then
I can be a little bit provocateur.
Sure.
That we have government in one hand and we have civil society, but civil society is not an harmonized basket. We have extreme rights, people who doesn't want the foreigners, people who are racist in civil society. So I think that divided like that may mislead you, especially in a world where nationalism is taking over. Thank you.
Thank you. I want to forward a question from the audience, from Camille. Hello, I would like to ask, how strong do you think the role of disinformation was during the pandemic, and how strong impacted it had on taking protective measures for general population and vaccination process? So all the conspiracy theory things and misinformation, what is your opinion on that? To Camille.
Maybe I can start again.
Sure.
I've been in Brazil a year ago. One of the very typical examples of how the misinformation and disinformation affected and brought this population into the point that they were mourning more than 500,000 dead people. And what I noticed was the complete damage and loss of trust to science. So it's not only about creating this feeling of uncertainty of what is happening, but it creates long-standing damages that are very difficult to repair later on. That was only one example. Of course, in other places, we had other types of example, and what is mentioned here by Camille on disinformation relating to specific campaigns against vaccines or against specific drugs was only one little, let's say, aspect of what we saw. The answer here, of course, cannot come easily because it's not easy to control information anymore. And again, I can bring within the picture the example of Ukraine today, where next to the victims that we have and the human lives that we lose, what we have lost is the truth. And we struggle to understand out of all this information what is truth or not. So we have to start looking at this world and what is about to happen next, being pretty convinced that misinformation will always be a tool for people, and will always have to be for us something to not just be aware, but do our best to prevent it. And how? Again, engagement with those part of the civil society, Agnes, that can really understand our problems in the same way. And to find also all leaders in the communities, to engage with communities, to work together. And that's how you can prevent all this wrong information. You create a narrative about what is going on, and you do it together, and this can be the best multiplier for them. They can amplify this message.
Thank you. First Gerald, and then Dr. Agnes, please. First.
Yeah, thanks. I think just to echo what Christos said, I mean, I think we found ourselves not only in a pandemic, but also in an infodemic where misinformation really became a major challenge. Not only that science wasn't heard, but science was even attacked, and health workers as representatives of science and communicating scientific messages basically being not only harassed, but occasionally even physically attacked. Let's not forget that, one of our health ministers resigned, not least because of the reason that he felt that he was personally threatened and didn't want to continue in such a working environment. Again, how do we address that? There's probably not a simple recipe. I think community engagement, as Christos mentioned, is certainly one that we need to explore further. We in WHO have even now a unit that looks at behavioral science approaches and try to develop scientific targeted approaches for certain community segments that seem to be particularly resistant to scientific and evidence-based advice, and try to target the messaging better also through civil society organizations, and we call it risk communication and community engagement. So also for the mere reason that I think in all emergencies and crises is actually, whether we want it or not, it is the local communities who are the first responders. I mean, yes, and then, local, municipal and national governments can mobilize resources, but we need to rely on communities and work with communities to build that system resilience for future shocks and emergencies.
Thank you. Please.
So I think that lie kills, and we know that. There are certainly 1 million people during COVID who die because of lies. Lies in everything. Making a mask a political statement, for example, and don't put mask and be dangerous for others. So that means lies kills. What is our objective in life? Is to protect life. So if we know that lie kills and infodemic is dangerous, why don't we act and make people accountable? There are some very, very decent head of states that has killed more citizens on earth than any extremist. And they are going to survive that very well. So if it is because killing with a lie doesn't make the life we lost important, okay. If my life is, you kill me with a bullet, then you are accountable. If you kill me with a lie, then you are not accountable. I think we are not serious. There are some countries when you lie to people and push them to death, you are accountable. And I think we should reflect on that. Liberty is not to say whatever if you are provoking damage to your brothers and sisters. So we should stop saying infodemic, we should start regulated that. When there is a bad governance, there is an international tribunal because people die. When there is infodemic, we should have an international tribunal because people die. Thank you.
Thank you, Professor Pinaguajo. Ambassador Schweitz.
Just add a word. Yeah.
Sure.
I think that we have seen that the misinformation is happening everywhere, and even if politicians are not presenting us with lies about the dangers of the pandemic, there are people who are refusing to face the scientific findings and act accordingly. What have we done here? And that's why we are supporting international big organizations like the WHO, because we know you have, Dr. Rockenschop, you have the network, you have the access to the local communities in the countries, and you know how to distribute the information the best way. Same is true for Médecins Sans Frontières, and a lot of information for the international organizations is coming from your organization, Dr. Christo. I know that was the case in Ebola, for example, many years ago. So I think that the information difficulties and people believing what they want to believe is something we have to we can only counteract by providing more accurate scientific information, but there will always be some who deny this approach.
Thank you. I have another question here from Rita Izaba to all panelists. how would you combine your available resources for an efficient healthcare logistics infrastructure in Global South regions? So a very question to the point. How would you combine your available resources for an efficient healthcare logistics infrastructure in the Global South? Anyone wants to start?
I'm not sure we can sit down all together and combine the resources that we have. And it's good that we don't do that. We all understand, of course, how important it is to have partnerships, but we have also to understand the different roles that we have. Like, for instance, WHO played this role of being the norm, the normative role in guiding us and producing scientific evidence to help others in this pandemic. And these others could be me, my organization, other organizations, or civil society, or universities, that each one have their roles. So the partnership is very, very important. But in terms of logistics infrastructure, one thing that, again, this pandemic taught us was that you can still have high quality standard of anything while trusting the regions and the local markets at the same time. You don't need to have, as we used to the last 40 years. And we were very proud of the quality of the drugs that we were distributing, because they were coming from places that have undergone 2 and 3 different controls before they were ready to be distributed in our operations. Now we're pretty convinced that we can have this local purchase opportunities, and we have to invest more on that. In the same way that we have also to invest more in the workforce, the resources, the human resources from all these places. When it was not easy to move from, let's say, Sweden and go to Brazil to provide some logistic support, we had to trust the Brazilian people, and they did the amazing job. The same applied with South Sudan when we ran out of a head of mission, and the South Sudanese guy could very much do the same job, understand the context and help. So this is another, and I'm sorry, I keep reminding to us today how important as all these shifts in our mindsets, in our mentalities, but this is also another area. And thank Rita for this question, where logistics infrastructure can be seen in a completely different way than we used to see in the past.
And also create systems, you know? You are not there to create logistics if you don't, logistic for what? You need to base it on a primary care, have a logistic between primary, secondary care, and tertiary care, and make it inclusive. So each country, it will be different because each country have reached some level. So don't say the Global South like that. It's many countries. So each country has to have its own plan. But also, I think that for donors, since HIV, you remember the big, they will come together all and help a country together. It never happened, never happened. So now the coordination at global level and the coordination at country level has to be taken in account. And don't build logistic in a country you don't help them to have their own coordination system based on who they are, their culture, their history, their system that is already there.
One direct question to you, Professor Benaguajo. In such a case, would you also rely on the military? I mean, civil-military cooperation is a tricky topic, but what?
Tricky for who? Tricky for who? Can I tell you something?
Sure.
Military are the young people with a lot of energy that we don't use when there is not a war. So what are you doing with them? Don't make them run in the roads and etc. Make them work for the society and the development. In my country, they have built health centers, health posts, etc. During this time of distribution of vaccine, in Rwanda, we were lucky because we were ready, we accept vaccine even if they have to expire in 1 month, because we will know we will distribute them within a month. In 1 week we can. Thanks to who? The military. Fighting malnutrition, I don't have enough track to distribute even HPV vaccine to the country because we want to vaccinate all the girls in 4 days. Who I use? The car of the military. They have 4 wheels, they are just green. We don't care. We put, and so the military are at service during peace. And we should stop. I grew up in Europe, you know, and I was a young person going to manifest a peace for this, the colonization of Guinea-Bissau, etc. So military, I was a little bit afraid of them. And when I arrived in Rwanda, they were almost everywhere because the peace was not secure. I had this reaction. But now, when I have a problem, I go to them. They have helicopter. The Ministry of Health doesn't have helicopter. With helicopter, at the end of the country, the vaccine are delivered in 1 hour. So use them well. They are young people that are misled in some way, but they are so happy to help you during peace. And use their energy for that. And you make them loved by the people. And then you make them love more the people. So yes, use them.
Okay. Gerald, how are you? Are you using military resources when you bring your vaccines or material into countries?
Depends very much on the context. Yes, I mean, we have been doing that particularly in natural disaster situations to tap into military assets to reach hard to reach areas that otherwise wouldn't be accessible. I think it's a bit of a different context. I mean, in the Ukrainian context, we trying to do our best to stay away from you know, working with military for obvious reasons. I just wanted to come back to the question of what would you do to build logistics. Well, first of all, as WHO, we work very much through the national system, so we don't necessarily have a big logistics capacity to start with. We do have for humanitarian operations, but I think that's a bit of a different story. But I don't think that the key problem is even logistics in that context. I think it was a bit the problem of the disbalance of production capacity and access to scarce resources, particularly to vaccines. Yes, there were obviously logistic elements when it comes to cold chain, which was particularly in the early days for some of the vaccines very challenging, but that was resolved relatively quickly. And there, I think COVAX also and the ACT accelerator played quite a substantial role in making those resources and capacities available to countries. But I think it's what now needs to be done is to have a more equal distribution of production capacities and also of research capacities, and I think it's very good that Africa moves forward with, you know, vaccine research and consolidating their capacity. I think it wasn't so much the problem of having PPE production in China. What was the problem is having PPE, personal protective equipment production almost exclusively in China. That was then part of the logistic problem. And I think that needs to change. Countries need to work to have a certain level of independence and independent production capacity, at least for those global public goods, or work closer together to ensure that those global public goods are then available for everybody who needs them.
Yes, please, Ambassador Schweitzer.
Thank you. Dr. Rockenschaup answered maybe half of my question I would have had, because we invested into and believed a lot in the success of the ACT COVID accelerator and this combination of partners working there, also with the goal to build capacity in health systems. That was your original question. And I wanted to ask you from the WHO perspective, whether you think, from your perspective, whether it really worked, or can there be improvements in one way or the other?
I think there can always be improvements, and I'm not saying everything worked perfectly, but I think on certain aspects, I mean, all countries who benefited from COVAX interventions had to develop a vaccine deployment plan, which was, eventually looking at how can we strengthen the health systems, how can vaccine distribution be strengthened, how can primary care be strengthened as a distribution form, and so forth. So I think there were certainly, really very strong elements that were going into system strengthening efforts. But to also put things in perspective, there were also lots of challenges, obviously. And I think we need to do a careful evaluation and draw our lessons to then fine tune the interventions accordingly.
Mm-hmm. Okay. I think that will be the last question from the audience. We have roughly 10 minutes to go before the wrap up. How can health systems extend to people on the move on migratory routes? This is often the role of humanitarians. What is the responsibility of states? We know that 90 million people are fleeing or have been on the move. How is the situation for people in non-state control areas in conflict? Christo, please.
It comes in a very difficult moment for our movement, and I guess for the humanitarians, because it is a lot related to what we say about accessing those that they are most neglected, most in need, and excluded. And I bring in my mind places where they are controlled by non-state armed groups, like in northeast Nigeria. I've been there a year ago. And very recently, we had to pull out from that area. The Anglophone region of Cameroon being another place where any assistance you provide is perceived by the Cameroon government as assisting the terrorists. So with all these counter-terrorist frameworks, it has become even more challenging to address and access, actually, the population, especially those controlled from non-state armed groups. So just to answer to your question, I think we don't have visibility of what is happening these days, and we struggle a lot to gain access. And we know that they have been both infected as well as affected by the pandemic. But it's one of those pockets of population that we know less than anyone else. And then the refugee camps, it was again one of our serious concerns, because we have already seen inhumane conditions in what they call detention centers or areas to welcome the refugees. And we have been extremely worried that they would be left behind in anything related to COVID, which actually happened. And today we see that we try, when we struggle with WHO, with everyone, to get to activate the humanitarian buffers in order to have also the possibility to apply some vaccines to these people. But what is happening in Cox's Bazar, what is happening in Al-Hol camp in northwest Syria these days, what is happening in the Dadaab camp or detention centers in Greece, not to mention the Libya, which is one of the most shameful conditions this moment, is something that nobody has clear visibility, but we all can assume that the situation must be extremely worrisome.
Thank you to share some light for us. Gerhard, what is your point on that?
Well, let me perhaps start with a positive note. I think what the EU countries have decided to grant temporary protection to Ukrainians who had to flee the country, I think is a very, very positive step, obviously, because that, facilitates access to healthcare those more than 4 million who had to leave the country. But let's not forget that there are 6.5 more that are internally displaced in Ukraine. And I think what we need to be very careful is not to create double standards or different standards for different groups of migrants, refugees. And I think we tend to mix those two categories together, although they are quite distinct groups. But I would agree with Christos that we really don't have the full picture. I'm also just back from a mission from Gaziantep in Turkey to look at our cross-border program there for northwest Syria, apart from the fact that, we are facing now a situation where the Security Council resolution might not get extended, which, might create a whole new bag of challenges there. I think we are facing a whole lot of other crises where we don't even capture the full magnitude of vulnerabilities that we're collectively not really able to address at the moment. And I think our Director General, when he was briefing the Security Council the other day on Ukraine and the health attacks there, he made a very strong point and the plea to not forget about the other crises and the vulnerabilities elsewhere in Afghanistan, Libya, Yemen, and so forth. So I think we really I think we find ourselves in a moment where I think never in history we had so many crises and emergencies that the international community needs to deal with without necessarily having the same increase in the resources that are available to address the humanitarian needs.
Thank you. Dr. Agnes?
I'm going to be a little bit provocateur here again. For Ukraine, it was very good what the European countries have done, but they should do that for all, not because they are white people. You know that the Black students, more than 4,000, were not allowed to be entering in Poland and were left in Ukraine to die. So you can do good actions, but you need to scrutinize, because if you tolerate that, it will be a fire on oil in other situations, and Europeans have tolerated that. We didn't get opportunity to bring back the Rwandan that were trapped in Ukraine, because they were not considered as refugees. And we were ready to pay for them to come back home. They were our kids, our students, sent there to study. Thank you.
Yeah, thank you for reminding us on this shameful situation there at the borders. There have been some reports about students have been turned back. We should share some light, definitely. Thank you. Thank you for highlighting this. Please, Ambassador Schweitzer.
Thank you. And what Dr. Vinagrao just said, that was also addressed at the development ministers meeting of the European Union. And I think that since then, there has been progress. Students from African countries, also from Asia. I think India has a lot of students in Ukraine. The Ukraine were able to return to their countries. But I want to add a few other points there. Of course, the free and unhindered access and the safety and security of aid workers, of people who provide the much needed assistance and basic services is also a big topic. That's a topic in Ukraine, that's a topic in Afghanistan, topic in other areas, the areas of non-state, where non-state actors operate was mentioned. I think here what we do is we are supporting organizations that have access, like the ICRC, who has a good reputation and access usually to all parts of society in a country. And I think that is what we can do in such situations, to answer the question of Rita, I think.
Thank you. We have a few minutes left, and what is planned according to our script here is a final message, conclusion, appeal from each panelist, 1-2 minutes. If you want to, you're welcome to do that, to share with us your conclusions also from this discussion before I hand over for a wrap-up to Annelies Willing. Anyone who would like to start, please come forward and share with us your thoughts about today or whatever you want to share.
If I can start, Andreas, and I just want to make one comment, because I think at one stage it was said that, you know, MSF is reluctant coordinate, or, you know, has a bit of a different approach to coordination. I just would like to give an example where we worked very well with MSF in the Gaza context. We had a very close interaction with your predecessor, Chris Du, there with Dr. Joanne Liu, who, you know, came a number of times, and we had even a joint project on addressing the health needs of trauma patients, particularly gunshot injuries and osteomyelitis treatment and so forth. So I just would like to make that point that it also depends on the local context, and there are areas where MSF is collaborating very, very closely with other agencies like WHO. Also, by the way, in the Ukraine, we have very good coordination with health cluster partners and MSF on the ground. I think, yeah, I mean, I don't have any wise words really at the end, but I think what we certainly need to do is to carefully look at the lessons that Corona has told us. And one is that, you know, we can no longer see health systems as an area that is an expenditure, but we need to really see that as an investment. We need to have the adequate resources. We need to build and consolidate systems, because a strong and robust health system based on a very strong primary care base, I think is certainly the way forward to be better positioned to absorb future shocks, emergencies, and to be better able to protect people from negative health consequences in the future. Thanks.
Thank you, Gerhard. Who wants to start next?
I can be next to thank Gerald, first of all. Yes, indeed, we learn from our lessons, and everyone needs to do the same. Now, when it comes to the pandemic, again, I'll remind the three main bullet points that I raised at the beginning, which is about understanding that this is not over. And before we start preparing about the next pandemic, we have to really take a good look at what is happening today and how we may need to be prepared for the next wave of this. The second is about all the ripple effects that we touched upon a little bit, but it is more, and it is related to different contexts, different consequences. So it's not just about how many and how much have they been infected by COVID-19, but also how much and how many have been affected by this pandemic in all over the world. And my third is very much in what we discussed about, you know, shifting the paradigm from charity to treating everyone equally, from the paternalistic approaches of providing humanitarian medical aid or any kind of support to something that can really treat everyone in a way that will multiply the outcome of this. And of course, don't let the markets do what we have to do. Don't expect that these systems can really resolve the problems. They are here only to make profits, and they know how to do it, and they do it very well, as we can see. But the notions of solidarity and common goods, they come from us, from the political leaders, from the community leaders, from all those people that they are here because they do care about the others, and they don't just care about raising shares in Wall Street. So I want to really thank you all for this. It was a great opportunity also to take a snapshot of what is happening today and have these exchanges. And I hope that we helped also the audience and we answered at least their questions, that they were very many and very interesting. Thanks, Andreas.
Thanks. So who's next?
I will say that don't forget that you build the response in between crises. And also, it's not that what is done is not well done. It's just that if you want to help country to be ready, and even you need to make them ready to run the health sector in an inclusive manner, coordinated and integrated manner. The rest is also accountability for everything. I'm revolt against a world that allows people to die just because powerful people are lying, and also they take your taxes to help factories or manufacturers to do vaccine, and after that they make you pay the vaccine, and they let them make profit for that. So there is a lot of accountability, and if we are not attentive, there is no more amnesic than the human species. So we have to remain vigilant. Thank you.
Thank you very much, Professor Binaguajo. Over to Ambassador Schweitzer.
That leaves me. Thank you very much. And thank you also to the panelists for the interesting discussion. I think yes, I agree. Of course, we have to draw the right conclusions from the lessons learned during the COVID response. I think that what we saw in the beginning, and I have to come back to distribution of pills in this, the distribution of vaccines and vaccinations was the way to go. And there was no time, as we all were surprised, to build a long-term strategy already at this point. But in all our other work in humanitarian assistance, in development cooperation, we are including a broad variety of stakeholders when developing ideas and in the political documents. I want to just say a few points. So we are, of course, working closely in concert with all our partners, the European partners. Team Europe initiative, there's the goal, and I've mentioned that, I think, to distribute 700 million vaccine doses by the middle of 2022. We need to work more with all our partners, also in multilateral context. Joint multilateral coordination efforts have to be strengthened, and we have to include in our humanitarian assistance, we have to factor in the COVID response much more than we did in previous years, of course. I want to assure you that we will continue with our support, our humanitarian assistance from means of the Austrian Disaster Relief Fund, also bilaterally from our Austrian Development Agency. And we will take the needs posed by COVID-19 and multiple crises into account when drawing our current and new strategies, improving the current and drawing the new strategies. And we also, and that was mentioned and not enough by me, I think, we're trying to implement the so-called triple nexus, and we are trying to break down the silos in our directorate. It's easier because we are all together between humanitarian assistance, development policy, and peace building. So we're very much aware of the importance of that. And thank you to all of you and the audience, and thank you to you, Mr. Papp, and of course, Annelies.
Okay, that leaves me only a short time to say thank you for the open discussion. I enjoyed it a lot. I hope the audience too. And I hand over for a wrap up to Annelies Willi. Thanks.
Well, thank you so much. A little bit of a tough task now in front of me. Anyway, I would really like to thank everyone for bringing your expertise and experience to the table and engaging in such a constructive and open exchanges for the last 2 hours. I think we got some inspirations and ideas, and I think they were all addressed in a very insightful manner. And I would like to also thank the colleagues from the steering group and the supporting organizations, as well as to Spacewatch Global for the technical support. Well, what are my takeaways from our time together, which is just a glimpse? Yeah, I cannot summarize everything. What I heard was a very compelling call for more solidarity, equality, and accountability. I also heard that institutional structures that will allow quicker and more equitable responses will have to be implemented. For example, strong primary care, inclusion, more cooperation, partnerships. And of course, I heard we will have to learn from each other. We'll have to learn more from each other. The global south from the global north, and the global north from the global south, both. I also heard that we, and in particular, let's say also governments, need to support a comprehensive access to healthcare, not only COVID-19 related, and this especially, as we have heard, for the marginalized and vulnerable people. We need to invest in equitable global health, thus creating health systems that are resilient, sustainable, and leaving no one behind. And health systems of the future should have the ability to prevent, to mitigate, and overcome crises, and be able to cope with these multiple crises, as we have heard. And it also has to become a priority. I also think that humanitarian actors are somehow called upon to particularly explain how the effects of the pandemic in multidimensional crises play out. I think this is also quite important. And finally, always very important, we and in particular governments are asked to commit and to provide, of course, sustainable and adequate financing of development cooperation and humanitarian aid. So, ladies and gentlemen, excellencies, let me close by thanking Andreas Papp for his excellent facilitation, my colleague Monika Stumpf-Hulserei, the Congress Manager, for her engagement, and all of you, of course, for your time and attention. 1 second, before we finally close the session, we would like to ask you to participate in a very brief poll that will follow now. So thank you. And I hope to see you again at the 6th Humanitarian Congress Vienna that will take place on June 16 in 2023. So you can see the poll on your screen. If you would be so kind and just fill in the question, it takes you not even a minute. And as I said, hope to see you again at the 6th Humanitarian Congress Vienna that will take place on June 16 in 2023, sorry. And until then, ladies and gentlemen, stay safe and healthy. Thank you very much. Have a good day. Bye-bye.
Thank you.
Bye, everyone. Thank you.
Thank you.